Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology, regulations, and culture. My guest today is none other than Mark O'Hara, who is the managing director and co-leader of AArete's healthcare payer practice. AArete is a global management and technology consulting firm. Mark, welcome to the Tate Chronicles.
Thank you very much. I'm glad to be here, Jim.
Mark, in healthcare, and especially in healthcare reimbursement, it never stops. There's no end to the changes, as opposed to many types of businesses where if you have a restaurant, you feed people and you get paid. In healthcare and healthcare reimbursement, everybody has to look, if they're wise, ahead to where the regulations may go, where the technology may go, all that kind of stuff. So before we get too deep in the weeds, tell me about the kind of work that AArete does in terms of the, a payer side of things. What kind of consulting do you do? How do you figure out what the challenges may be, and how do you help folks address those challenges?
Sure, happy to, Jim. So as you noted, we are a management and technology consulting firm. We specialize in driving profitability improvement, digital transformation, and also doing strategy and change efforts for our clients. We have a digital first mindset, leveraging our market intelligence, as well as deep data analytics. One of the things that we really focus on is not just identifying the opportunities, making sure they're actionable and implementable. And one of the things we really focus on is being with our clients through implementation of initiatives. So not just providing conceptual ideas, but making sure they're real and making sure that they end up hitting and improving the bottom line, while still ensuring the quality of care for the members is met for our payer clients.
And so you payer clients. So you're talking about large third-party reimbursement organizations, insurance companies.
Yeah, that's right. The insurance companies, and some are large. Certainly, we've all heard of the names of the large ones, but many, then you've got the blues out there, which most of them operate in a single market, and you've got a lot of smaller regional plans, health plans, provider-sponsored health plans. And those tend to be, so you're not-for-profit, mission-based organizations. And then there's a lot of them around the country as well.
Yep. Mark, I was really glad I was going to be talking to you today because over the last few weeks, I've been thinking about, some of the challenges for the payer community. And so let me kind of put out some of those challenges I think that your clients have to address and how you're helping them address those. So we've had the Affordable Care Act for a number of years. And so this year, there's no longer rebates, and a lot of folks dropped their insurance. I don't know what percent, but quite a few did, because all of a sudden health insurance got much more affordable. And so out of the blue, that must affect the payers' demographics of who they're insuring.
You're absolutely right. It does.
So tell me about that. I mean, I guess people started thinking, well, maybe that was going to happen. We need to figure out some way to be on top of it. So
it's interesting, and I think primarily we're focused on sort of that bronze level plan, right? So the gold level, that's a different, smaller population demographic, but where you're talking about the rebates that were subsidizing members who, really in a lot of ways you could think of them almost as Medicaid plus, right? They weren't eligible for Medicaid, but they needed the rebates to be able to afford insurance.
A lot of folks, Mark.
It's a lot of folks. That bronze plan drew in a lot of people who would otherwise be uninsured.
Yeah.
And when the rebates went away, what you ended up with is what called the young healthies, right? The folks who don't have acute issues. They don't have, necessarily regular need for insurance. They a lot of them just decided we're not going to do it. The mandate went away. Well, the teeth of the mandate went away years ago,
Sure.
and so they're dropping. So what's left? The population that's left, frankly, is a sicker population. Higher acuity population that needs the insurance even without the subsidies, right? The
Right.
rebate. And what that does is that just means that the insurers, the payers,
Mm-hmm.
they now have a sicker population, and so that the young
Yes.
healthies or that healthy population is no longer kind of subsidizing the sicker, and so
Right.
the costs incurred by the payers is increasing,
I bet.
and at the same time, it's almost a spiral. They can't raise the premiums for these folks, or more will drop because the math doesn't math, and then you end up with even sicker ones. And so it's this spiral that and that's why you're seeing so many payers exiting the ACA market, because it's just not financially feasible right now for them.
For those payers to kind of make those changes, to come up with new policies, to make those business decisions. I guess there's some analytics they can look at, but there's got to be probably some guesswork involved in there, because you don't know how many folks are going to drop out. I mean, in this particular example, is that the kind of service AArete provides, kind of hand-holding, because you can't just make a decision and that's it. There's got to be some ability to adjust, even though you can't adjust on a weekly or monthly basis.
Well, no, you're really looking at the open enrollment period, right, for that, and certainly we can help, and we do help our clients on that side of things and making those decisions. A lot of our work, really, though, is trying to help our payer clients lower the costs of the care they're providing. So, looking at the total cost of care, if you will, that they're incurring, trying to understand where are their opportunities to take costs out of the system, while not impacting the quality of care. A lot of clients, especially if you look at the smaller, the regional payers, your provider sponsor plans, it's a lot of government sponsored business, right? So it's managed Medicaid marketplace, those who are left in it, and Medicare. These are vulnerable populations. A lot of these payers are mission-based payers. We don't want to negatively impact the quality of care, and yet there's a lot of levers that can be pulled to try to reduce the costs, because there is kind of a ceiling on the premium. Right now on Medicaid, you're getting managed Medicaid, you're getting dollars from the state. Marketplace, as we talked about, you can only raise it so high before people aren't gonna do it. And even in the commercial book of business, you're seeing we all remember, Jimmy, certainly you and I remember the days where premiums at an employer go up 18-20% a year, and
Absolutely.
there's less tolerance for that now. The benefits group, the brokers, and the employees are not tolerant of those increases. So even those organizations that are commercial focused are seeing that sort of ceiling on revenue. The elasticity on the revenue side is less, and so it's trying to drive out some of the cost is really where a lot of the focus is these days.
Okay, let me throw another curveball at you, Mark. I've been wanting to ask somebody, and I've got you to ask. In a formulary, third-party payers, cover certain medications, and then out of the blue, over the last couple of years, GLP-1s coming to the forefront, and so that is probably the most widely adopted, desired prescription medication in history.
You're right.
And so, without too much warning, all the payers have to decide: are we going to offer this? How are we going to offer it? Is it going to be a very high tier medication? What kind of guidance and do you provide payers for formulary?
Well, that's a good question, and it's rapidly evolving. And I think if you look, on the government sponsored side, is it a covered benefit? And there, the answer ends up, being relatively straightforward. In a particular market, is it a covered benefit? And
yes,
and that's, ironically, that's where we find not, because that's changing. Not just that, there's a lot of things that change regularly, right? The guidance you get from CMS, the guidance you get from a state Medicaid director changes very, very frequently. Keeping up with that is difficult. Even with a single market health plan, not to mention the multi-market plans who have to keep up with, 20, 30 different markets and different rules. And so understanding what's allowed, is it a covered benefit on the government sponsored side? And if it is, well, then, a lot of it, it's a lot of work with a lot of other benefits. This is where you really, the analytics come to play. You look at what are our costs. Again, on the government sponsored side, you're getting what you get, right? And you negotiate a reimbursement rate with the providers. This is, the pharmacy side is a little bit different, but then what often you need to be doing with these, where you see sort of your costs because of a covered benefit, right? Your costs are just kind of going the wrong direction. This is where you have the analytics, and you're able to take that to the state, to the governing body, and make a case for a rate adjustment. Whether it's a particular rate cell or whatever it is, to just demonstrating through facts. And that's really, sort of our focus is sort of that fact-based analytically. Look, here's the reality. Here's how much we're spending on it. Here's how much you're reimbursing us. At a very simple level, it becomes math. And, working with the states, you see a lot of this on the behavioral health side as well, because you're seeing a lot of increased utilization on behavioral health. Fortunately, the stigma that existed around a lot of that has dissipated, and so people are getting the care that they need. But what we see is the reimbursement rate, the PMPM rates trail that. And so a lot of it is educating the states, the market, that look, this is what your policies have led to, the utilization it's led to. We're not allowed to limit visits. We're not allowed to do this, that, and the other. So here's what we're seeing. So if this is what you want, that's fine. We love it. Our members are getting great quality of care. Here's a couple spots where we think it might be a little bit of waste in the system. So maybe we ratchet this back. But then here's where, the reimbursement needs to adjust to account for the fact that it's costing money. And so a lot of that, claims data analytics, understanding where the cost trends are going, all of that has to be done in a very robust. It's never real time because, it takes a little bit of time to get claims paid, but within a, near real time basis, because you could in a quarter find yourself really upside down. And
absolutely.
And even for these mission-based payers, there's a saying goes, no margin, no mission. You have to, you can't continue to lose money and continue to serve the vulnerable population.
Mark, you got to keep the lights on.
But that's true. That's very true.
Keep the lights on. Let me just mention to our audience, if you're just joining us, I'm Jim Tate. And on this episode of the Tate Chronicles, I'm speaking with Mark O'Hara of AArete. Let's say you have a new payer that feels like they need your help. And so they bring in you and your associates from AArete. What's your first step? How do you do an assessment? How do you figure out where they need help? How does that work?
That's a great question, Jim. I think what we like to say is data informs everything. So oftentimes what we're asking for is line level claims. It tells such a great story. It really can help you understand so much of where, that's the cost, right? The cost is in the claims.
Yeah. What do you mean by line level?
Well, so not getting summarized, here's how much we're spending at this. the actual claim line, right?
Okay.
Every claim line, that it has the procedure codes, it has, everything that was done. So then we're able to do, the analysis that goes into that to understand payment accuracy, right? Are you paying the claims as per your contracts and per your payment policies? We all know how complex those contracts can be and how ever changing the payment policies can be. And because everything pretty much is manually configured, there's errors, right? Those are very, relatively simple, easy, provider, we're supposed to be reimbursing you at X% of Medicare. Oops, we're not, or we didn't account for, some permutation of it. And so, finding that payment accuracy piece is something. But then it can get very, how are the claims being paid per sort of market standards? Are you abiding? Have you implemented CMS standards? Right. We're not talking about draconian prior auth rules. What we're talking about is standard industry expected norms on payments. Then you get into even more into the details around your membership, right? Trend analytics. That's a huge thing. That helps you understand what's coming, right? So understanding where are we seeing upticks, either in a particular procedure, a particular provider group. What are we seeing in terms of cost and quality? One of the things we like to do is kind of take providers, almost a 4-box matrix, right? The high cost, low cost, high quality, low quality, based on a number of different metrics. What's interesting is more often than not, you don't have to pay top dollar for high quality, for better outcomes. And so it's understanding which providers are really supporting your population in the best possible way. And let's then try to steer membership towards that population. Let's look at where are procedures being performed? Are members going, to an outpatient facility or inpatient versus a freestanding facility? A, the freestanding facility is cheaper. B, I don't know about you, Jim, but I'd much rather have my X-ray or MRI done at, a freestanding facility and than have to go into the hospital. Right. I try to avoid hospitals ironically as much as I can. And so that ends up being a great win-win for your member and for the plan itself.
I'm glad you brought that up, Mark, because as the payers are making adjustments, the providers are making adjustments.
Mm-hmm.
And so you brought the thing about place of service.
Yeah.
So anybody who's given advice to hospitals, will say, well, if we're going to do this procedure, if we do it in an inpatient setting, we get reimbursed this. If it's going to be an ambulatory surgical center or ambulatory center, it's this. And so just bottom line is they're going to try and do it in the way that's most beneficial for them.
Yeah.
And so that puts the payers in a position of kind of reactive mode, I guess.
Yeah, I mean, to a degree. What's ironic is you'll see providers, the actual doc.
Yes.
They'll have days where they're at the ASC, the ambulatory surgical center. They'll have days when they're in the hospital.
Yes.
And if you schedule the procedure on a Tuesday, well, it's going to be inpatient. If you schedule it on Wednesday, that's what the doc's at the ASC. And so some of it is just that education for the members. At the end of the day, members are generally, much happier to have something done in an ASC than in the hospital setting.
Sure, of course.
And so really, there is a little bit of a tension there between the providers and the payers? Sure. But at the end of the day, and again, if you look at, whoever it is, but especially your government sponsored business, these health plans are fiduciaries of the government, i.e. the public's money, right? So they have an obligation to try to get to the lowest cost, highest quality care. This isn't, this is literally taxpayer dollars that are covering this. And so, identifying where we can get high quality care at a lower cost is really, that's what the plan should be doing. because it does benefit, ultimately, you take it up a couple steps, it benefits the taxpayers because it's less cost
Sure.
to the taxpayers. Or on the commercial side, it's less cost to the company who's paying the premiums, for their employees.
So in your clients, the payers, you have an inside detailed view of what's going on with them.
Mm-hmm.
And so just by AArete having that exposure to that data, I'm sure there's benchmarking that you do. You take a new client and think, oh, you're doing pretty good, or you're in trouble.
Yes.
We need to make some, and they may not have that information. They need somebody like you and AArete to tell them.
That's the reality. Yeah. I mean, certainly if you look at, I know I mentioned before, so your provider sponsored or regional, a lot of these mission focused, not for profit payers, they simply don't have the depth of ability. It hasn't been part of their culture as organizations, and you look at provider sponsored plans, right? These are health plans that are owned by a big provider system, right? Well, they were started as an organization. These providers typically, and there's exceptions, of course, but typically started them to be a way to serve the community. Oftentimes, they are Medicare, Medicaid health plans, serve the community, mission based, and also steer members to the provider system. Right, the term often uses heads in beds. And so you'll see, and so historically, the provider didn't, if they weren't making, the payer wasn't making a ton of money, it didn't really matter. It was a great way to kind of steer members. And depending upon the payer, it could be 40 to 60%, are kind of captured right within the provider system. And then the rest of the cost goes to other providers, specialists, that sort of thing, ancillary services. Well, then COVID hits. Now your payers are actually making money because, especially the managed Medicaid ones, because redeterminations is suspended, right? So you're getting, the revenue continues to come in. The providers, however, as we all know, we're not doing very well financially.
Right.
Now we're in our post-COVID era, and the providers are still not doing very well. And also with redeterminations restarting, and some of the challenges that they continue to face, they're not doing well. And so now you've got this case where providers are taking a hard look at their payer owners, and these are organizations, again, it hasn't been something, they've never had to do this, so it's not through any fault of their own. Everyone's got multiple priorities in their life. Driving costs out, doing the analytics, really understanding, it wasn't one of theirs. It was serving their community, mission-based, driving members, steering members into their provider parent for typically very, very high quality care. And so what we find are they just don't have the infrastructure in place to do the analytics, to focus on and to really create that culture of constant improvement around your cost structure. And so, oftentimes it needs a little bit of a jump start. But the reality of it is the ideas, the initiatives themselves are great. But if they don't get through to implementation, it doesn't matter, right? So what we see are these payers, they don't want more ideas. They want action. They want things to get done. They want to see it hit the bottom line. And they also still have this mission, their mission focus. And so they don't want to negatively impact their members. So there's a little bit of a cultural shift that has to happen. And a lot of times just getting some support on that, getting that going. But they're more and more realizing that, operating as they did, you're not going to remain a going concern.
Mark, we're almost out of time. I've saved a curveball for you here at the end.
All right.
I'm going to give you about a minute and a half to answer this. How is the work you're doing in supporting these payers benefited by using AI?
That's a great question. And, one of the things I had mentioned earlier was the manual process around even, as an example, claims configuration, right? Claims payment configuration. So a big provider system contract, as you probably well know, Jim, from your experience, really, really complex. Lots of carve outs, lots of different permutations. Well, those are kind of manually entered. Using AI to take that contract, pull out the metadata, understand what it is. Here's what the terms are. Here's how you can use it. And then ideally start feeding that automatically into your adjudication system. So you take the fingers, so to speak, out of the equation. Now you're eliminating a huge potential for error. And every time there's an amendment to the contract, there's risk of error. And so you're taking that out of the equation. And that's a great spot for AI to sit, is where we've got the manual, sort of that manual typing, whatever you want to call it, pulling that out, also using AI as part of the trend analytics that we're doing, right? How to better anticipate what's going to be coming, where are your members going to be going? As you mentioned before, once they're already utilizing it, in some ways it's overutilizing it or shifting utilization patterns. Now you're reactive, right? Getting proactive, looking at where do we anticipate the members shifting their utilization to, and then how can the payers provide, we support the payers for providing the best possible care at the most appropriate cost.
You did a good job in the time.
I tried.
I gave you. So I'm going to, the easiest question for my final one, how can folks and our listeners find out more about AArete? Where can they go?
The easiest way would be our website, AArete.com. That's certainly the easiest way to get a hold of us, and we're just love doing what we do and love supporting this industry and the members and making sure everybody gets the care they need.
Mark, I'm glad somebody's doing it. To our audience, thanks for joining me on this episode of the Tate Chronicles, and of course I offer a special salute to my guest today, Mark O'Hara, from AArete. Mark, thanks for coming aboard today.
Thank you for having me, Jim.
You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.